Dr. SANE will be speaking on flat irregular PED in chronic and recurrent central serous chorioretinopathy, our experience.
Good morning to all of you. I shall be sharing our experience on flat irregular pigment epithelial detachment in chronic and recurrent central serous chorioretinopathy. I have no financial disclosures to make. So central serous chorioretinopathy, the characteristic features are serous retinal detachments, mainly involving the macula, and the other characteristic feature is pigment epithelium detachment. When the duration of the disease is more than 6 months, we term it as chronic CSC. In acute CSC, we get focal PEDs, whereas in chronic CSC, we commonly come across irregular or dimpled PEDs with a low height, and we can distinctly see the Bruch membrane underneath the PED. So these are termed as flat irregular PEDs. As we can see here in the picture, there's a flat irregular PED and the Bruch membrane is clearly seen underneath the PED. It is important to detect these FIPEDs because it has been shown that the resolution of SRF was found to be significantly lower in presence of FIPEDs compared to focal PEDs, and they may respond better to intravitreal anti-VEGF agents. When these FIPEDs are associated with a type 1 CNV, it has a worse visual prognosis. So with this background, I come to our study. The aim of the study was to assess the rate of FIPEDs in chronic and/or recurrent CSC. It was a retrospective observational study with consecutive patients with chronic or recurrent CSC included who presented between January 2018 to July 2022. We define chronic CSC as persistence of serous retinal detachment for at least 6 months, and recurrent CSC was defined as an episode of acute CSC following a previous episode with a complete resolution of neurosensory retinal detachment in between. A comprehensive ophthalmic examination was done for all patients, including best-corrected visual acuity with logMAR and dilated fundus biomicroscopy. Optical coherence tomography with Cirrus HD-OCT 5000 was done to detect FIPEDs and also to determine subfoveal choroidal thickness. OCT angiography was done to detect a type 1 choroidal neovascular membrane, which was defined as a pathological flow in the outer retinal slab or the RP sub-RP slab in the area of the FIPED. If a 3x3 millimeter scan did not detect a CNV, the absence was confirmed on a 6x6 millimeter scan as well. All slabs were sequentially checked to avoid projection artifacts. So I come to the results. 31 eyes of 28 patients were included, out of which 25, that is 89% patients were male. The mean age was 47.7 years. Mean logMAR best corrected visual acuity was 0.28. 12 out of 31 eyes had a previous history of treatment for CSC, out of which 10 had focal laser, one eye each had focal laser and photodynamic therapy, and PDT with anti-VEGF injection. The mean subfoveal choroidal thickness was 393.4 microns. So we detected FIPEDs in 22, that is 71% of the eyes, and a CNV was detected within these FIPEDs in 8, that is 36.3% of eyes. The sub-RP space was at least partially hyper-reflective in all the FIPEDs which were associated with CNV. So this is a representative photograph. On the left-hand side in image A and B, we can see an FIPED with type 1 CNV. And on the right-hand side in images C and D, we can see an FIPED, but there's no CNV detected. It has been proposed that a long-standing PED in chronic CSC can cause Bruch membrane disruption, and that can result in CNV formation. Female gender, choroidal vascular hyperpermeability, poor vision at baseline, old age, and FIPED with a larger width and RP thickening are few of the risk factors associated with development of CNV. It is important to discriminate between the avascular and vascular FIPEDs as it has a prognostic significance. A conventional dye angiography is not very helpful in detecting CNVs, as the late hyperfluorescence and the ill-defined leakages which are seen on the dye angiography, they are obscured by window defects caused by RP atrophy due to the chronic RP dysfunction in chronic CSC. OCTA, on the other hand, is a non-invasive modality. It does not have the disadvantages of the dye angiography, and it has a sensitivity of 86 to 100% and a specificity of 96 to 100% for detecting CNV in chronic CSC. So in our study, we detected CNV in 36.3% of eyes in the FIPD area, compared to the previous studies in which 18.9% and 35.6% respectively CNVs were detected. These are few of the limitations of our study. A selection bias due to retrospective nature of the study, a relatively small sample size were some of the limitations. We did not temporally evaluate the FIPDs and CNV formation. Eyes with previous treatment for chronic CSC were included and not excluded, and the diurnal variation in choroidal thickness was not accounted for. So to conclude, FIPDs were found in 70% of chronic and recurrent CSC eyes. CNV was detected in more than 1/3 of these eyes, and further long-term studies required to elucidate the natural history of FIPDs as well as the potential role of anti-VEGF in presence of FIPDs with or without CNV needs to be studied. Thank you.
So, since you've studied patients with chronic and recurrent CSC, did you do any correlation with by using EDI to identify the condition of the choroid? Was there pachychoroid evident? Because that would help to differentiate between CSC causing CNV and or whether this is pachychoroid neovasculopathy.
So an EDI OCT was done to determine the subfoveal
What
choroidal thickness.
percentage of patients had pachychoroid disease which was persistent?
So in relation to patients with FIPDs or without, we have not analyzed their data because the sample size is relatively small for this study. This is just an incidence study that we have done, and we'll continue it to in between the subgroups with FIPD without and without CNV, we'll be analyzing those factors.
Okay, and the example that you showed, the presence of FIPD without the presence of neovascularization on OCTA, the reflective signal between the Brooks membrane and the RP was hyperreflective, whereas the one that you showed where there was neovascularization, the reflective signal between the RP and the Brooks membrane was more translucent. So do you think that that could be used to differentiate between whether an FIPD has or does not have neovascularization without using OCTA?
So based on this small sample size, some hyperreflectivity gives us a clue to find out if there's a CNV on OCTA, but it cannot be correlated directly that a hyporeflective will not have a CNV or vice versa.
Okay, and did you confirm any of these findings by doing ICGA?
No. Systemic, no specific systemic investigations were done for this study. No, ma'am. Yeah. So as part of the general systemic examination that was done as part of the routine hospital visits, but it has not been mentioned in any of the previous studies that hypertension has any role with the incidence of FIPDs.
But she will not be marked. Age of next, she is allowed to present, but she will not be considered for the
not. Yeah. Not thought about it, but
absent, presenting with her absence.
We shall include it in the continuation of the study. Yeah. Okay.
Thank you.